What's up, guys? Welcome back to the Fresh RN podcast. I am Kati Kleber, and I have got Hannah Schlake here with me for yet another episode about very interesting patients.
Hey.
So we're going to just jump right into it. So if you listen to the last episode, we chatted about a trauma patient. This time we're going to talk more specifically about OMFS, or say it.
Oral maxillofacial surgery.
Maxillofacial.
So anything of the face, the jaw, they get into the neck, like your palate and like the bones around your eyes and your nose, all of those.
So we're going to chat about that because it's so darn interesting. And it's I've taken care of just like once or twice. But I was just telling Hannah, this was kind of like a little bit of a jarring experience in terms of physically seeing someone without half their face who is just feels terrible, right? I mean, talk about body dysmorphia stuff. Like, it's one thing, because I've taken care of a lot of patients who have had amputations, diabetics, a toe, a foot. But to lose part of your face, that's huge.
And a lot of times it takes away your ability to talk or eat. So it is life-changing, absolutely life-changing.
Yeah, and then also, they're complex.
Yeah.
They're just a complex patient.
Yeah.
So it's just, having that be one of your 5 patients.
Yeah.
That's a lot.
It is. It's the one that, like, all right, this is where I'm going to spend a lot of time tonight.
Yes. All right, so did you want to do a full report, or you just want to tell me more about them?
Either way. I mean, we can... I have it all written here, so I could step report. Okay.
Let's example of what report would be like. Are you pretending your night shift? Today's? Yeah. Okay, so let's pretend you're working on your unit and you're giving report to me. I'm day shift. And I'm grouchy. No, I'm just kidding. I'm annoyingly perky right now, and you're so tired.
Yeah, I'm exhausted.
All right, go for it.
Do you have a name for this one?
Oh, so the last one was Michael Scarn. So this one will be Catherine Zeta-Jones.
Catherine Zeta-Jones. All right, perfect. So this is Catherine Zeta-Jones. She is 63, patient of OMFS. She's a full code. Allergies to sulfa. Past history of hypertension and squamous cell cancer of the mandible. So she came in on 10/1 for a scheduled PEG placement. And then on the 2nd, went back to OR and had a bilateral neck dissection, a right mandibulectomy, and then fibula free flap.
All these.
And she had a trach placed.
Say that last. So before the trach, what was that one?
Fibula free flap.
All right, cool.
Okay. She went to ICU after that. And on the 4th was downgraded to us. On the 4th, they DC'd her fully. She is now voiding fine. And we had a pretty good night together. So for as far as devices and skin and stuff, she has that PEG tube. She's getting bolus feeds. So they are scheduled in the MAR, but it's like 8, 12, 4, and 8. She's getting Gevity 1.2 through that. And I know that there's another bottle in the med room for you.
Oh, thanks. That's great. I don't have to order it. Wonderful.
For her trach, she's got a number 6 cuffed. Doing trach care Q8 on that. She's got OptiFlow going into that. For the flap, we are doing Q4 checks. She's got the internal Doppler, and she does have she's numb through there, so that is known. We've got numbness through kind of the neck and underneath the jaw.
Okay.
For her incision, it goes from earlobe to earlobe. It drops down around the jaw. And we're doing Q8 incision care, cleaning with half and half, and best tracing, which is there over on the computer.
Okay, thanks.
And then on the fibular donor site, It is on the right, and she's got a wound vac on that, and it's at 125.
Cool.
So she's got an 18 in the left upper arm and a 20 in the right lower arm. She's saline locked. She's NPO, and we do have the oral suction set up for her, just with like the Red Robin, just to help kind of control her secretions. Like I said, she's on OptiFlow. She's up with one. She moves quite well. Just some assist with all of our devices going on. Q4 Accu checks right now. She's voiding fine, using the bedside commode. For pain, we are doing the hydrocodone liquid kind through the PEG tube. We'll do vitals Q4, eyes, nose Q4, and like I said, the flap vascular checks Q4 as well. She does have a like dry erase board, the communication board, to help talk. That's about it. Any other questions?
Wow. Man.
Yeah, we got a lot going on.
We got a lot going on.
Yeah.
Oh my goodness. I want to hear more about this.
Yes. Okay. Let me tell you.
So so she had a PEG placement first. So that's like, we know this patient's not going to be eating through their mouth. Let's make sure they have a place for nutritional.
Yeah, this is going to be like a long-term solution for nutrition for her.
So talk me through the 3 things she had done. The bilateral neck. Could you just go through that?
Yeah, for sure. So the bilateral neck dissection, so that means they open up the whole neck, both sides. So like for the incision I said was earlobe to earlobe, so it kind of drops down like below the chin and goes all the way around.
Wow.
So if you are one to Google image search things, you can, but it's, totally opened up to like completely exposes the entire mandible.
Oh, and then you said she had cancer.
Correct.
And is that often the reason for this?
Yes, it is. So this is where cancer invades the bone of the jaw, your mandible down here. And so what the total mandibulectomy, the right mandibulectomy was, removing that part of bone that is affected by the cancer. And then the fibular free flap, that is where we take a part of the bone of your fibula, move it up to your jaw, and then secure it with all the metal going around so that you still have bone of your jaw, but it comes from your own leg. Wow. And then your leg is also, secured with metal down there so you can still bear weight and everything through it.
Wow.
Yeah.
That is wild. So I'll ask about the leg a little bit in a little. So, okay. So that was the bilateral neck, and then the and then the fibular free. So when they're walking, so this patient afterwards, would walking be tough?
It can be. We've got the wound vac going on, so just as far as like keeping cords out of the way, they need help. They will have pain through the leg, but they will be be able to bear weight and everything through it.
Wow.
Yeah.
Okay. So can you tell me what they look like in non-medical, like you walk in the room, because it's hard for me to imagine what this patient looks like post-operatively so that I'm not just like shocked by what I see. So I'm being sensitive. You know what I mean? Yeah. Tell me what they look like.
So they will have a very apparent incision going around underneath their neck and jaw, and their jaw itself will appear very prominent. It will be large. So you've got a lot of swelling going on. It will almost look like they have like a significant underbite. Okay. And it's just like a real big, thick jaw. And they're, depending on what all they may have needed to do as far as if they need to remove any teeth in the process because of the cancer, how far the cancer invaded their mouth as well. Their mouth itself will look different. Their how they carry it and are able to move their tongue some of these patients need part of their tongue removed, a partial glossectomy.
Okay.
So
could we have like drool, like just falling out of their mouth kind of a thing?
Especially if they're having numbness or pain like through their like under lip, if they're not able to just like hold it normally. So that's why we kind of have the suction to help control not only the secretions that are trying to go to their back of their mouth, but also coming out the front. We've got suction to kind of help them out with that.
So this patient had one half removed, but do you get patients who have their entire jaw permanently removed? Do they ever not put a new one?
So I haven't had it where the jaw is just removed and they don't have some sort of either like a bar reconstruction or some sort of reconstruction. That might depend on just the services that are in your area for this sort of cancer treatment. I haven't seen that. I've always had a reconstruction going on. Sometimes you can just have, like I said, just depending on where the cancer is. That's the thing. This is not like a defined, you have to do the operation based on where the cancer is. So if it's, part of this jaw or the teeth or part of the palate or the tongue sort of thing. So yeah, like I said, it's visually apparent. They will look different. They will use their mouth differently or not to be able to use their mouth. So just being cognizant of that. And sensitive to that when you're talking to them and, having the patience of the communication board, which we'll get to.
Okay. So that's the actual like surgery that happened. Then you talked about PEG tube with bolus feeds. Tell me what that means.
I don't think we talked about the trach.
Oh, I didn't write trach down.
Yeah, so they place a trach. So since we've got so much going on with their mouth and their neck and their airway, they will have a trach placed to just, check that box of airway is going to be good and out of the like swelling zone. And again, depending on the patient and their surgery, this may be more of a permanent thing, or this may be something that they anticipate, the swelling will all go down. We will get to a point where they can control their secretions, and they may be able to have the trach removed. Either sometimes before discharge, if it's like a lighter surgery, or some, in a couple weeks. Totally depends. It's a question for the team. Like, for this patient, what's our plan for the trach? Sort of thing.
Man. So, talk about all the bells and whistles that a patient could possibly have. I mean, there certainly are more, but this is a lot. Okay, so that is neck up. So talk to me about how we're going to feed them and what bolus feeds means and all that.
Yeah. So they've got a PEG tube. So that is just the tube going straight into their stomach through their abdominal wall. And we'll do bolus feeds for this patient as opposed to continuous feeds. Patients can also have like nocturnal only continuous feeds. So bolus feeds will just be like a mealtime, like this is when you're getting your food. So like I said, hers are at 8, 12, 4, and 8. So 4 times during the day. We'll give the prescribed amount of the tube feed with, the prescribed flushes of water beforehand and flushes of water afterwards. So that will give them their fluid requirement for the day, the calorie requirement for the day, their fiber for the day, all of that. It's complete nutrition.
So then you would be having a dietitian who is on board, who's, the physician will say they need this, and then the dietitian figures out the rate and all that, and they put in the order, and then it's your job as the nurse to administer it per the orders and watch the site and take care of the tube and yada, yada, yada.
Yeah. And if they're, if they're on continuous, that will have a pump. If they're on bolus, you'll be doing the bolus either by, syringe or gravity, however it's prescribed, or how the patient is tolerating it. Some patients can't tolerate you, pushing the food in. They need it to go very slowly. And if this is a long-term, which it is going to be a long-term thing for the patient, educating them along the way, because they'll be doing it at home. Getting them involved as we get closer to discharge. The patient will be doing it while I'm over here getting my meds ready. I've brought in the food and scanned it. You go, let's get you set up. You go ahead.
Yeah, you want them to do as much for themselves as possible. Yeah, because they are going to have to do that until it could be permanent, right?
Right.
Holy moly. Okay. And then we talked about the trach. You said we do trach care Q8 and they have OptiFlow. Can you explain that?
Yeah, so OptiFlow, is like the oxygen delivery kind of. It also delivers humidity, which is so important for trach patients. You need our normal airway humidifies our air as it goes down into the lungs. But when you are bypassing that upper airway, you need humidified air to go in. Otherwise, the mucus will get real thick, get real sticky. You can get mucus plugs. It's tough to move it up and out.
Which can close off their airway. Right. Yeah. And then you've got a really big issue on your hands.
So you always want humidified air to a trach. So OptiFlow, that's probably the brand name, you think?
I don't know. Okay. But yeah, they have to have that. Even if they have great oxygen sats.
Right. It's not because they need oxygen support or necessarily like a higher flow, higher concentration. It's for
for humidity.
If they happen to need oxygen needs, you can use this device to add onto that. But for trach patients, it's primarily for the humidification. And then Q8 trach care. So that will include cleaning around the trach site. If they have some sort of like dressing kind of on their chest, like an absorbent dressing to catch their like secretion.
Yeah, because those fresh trachs, they got their secretions.
Lots of secretions.
That was so scary to me as a new nurse, like dealing with trachs at all, but then to have a new one where they're coughing and it's coming out of the trach.
Yeah.
Or if it's stuff oozing around it. Oh, that was intense.
Sometimes these are patients that you just put, a towel or a washcloth under them. If they're having enough coming out, you know what? Every time you go in there, we just change the washcloth, and that's okay.
Yeah, and that's not how it's always going to be, but this is just what we got to do at this time.
We want those secretions up and out, better out than in. Just encouraging them. If they're feeling like discouraged from that happening.
Yeah, like this is normal. This doesn't mean something's going wrong. We got to get that gunk out. Yeah.
So cleaning around the whole trach site. And then, so hers is a disposable kind. So that means the outer cannula stays in her neck, and the inner cannula we change out every 8 hours, just because it can become plugged with mucus getting all up in there. And
infection's a big deal too. Like we have a direct line from the outside world almost to her lungs, right? We don't have all that upper airway to protect. So we have to keep this bad boy clean. Yeah. Don't want little micro guys crawling down in there and snuggling in her. Yeah, no, we don't want that. So we got to clean it all the time.
Yep. So it'll be changing that cannula, and then if the patient needs it, suction going down in there. So that's a sterile procedure.
Yep.
Depending on your facility, sometimes that might be like a respiratory therapy only.
Yeah.
That might be a nurse thing. What else would take care? If they have, so these new trachs will have it typically sutured to them.
Yep.
Just generally, if you're carrying with an older trach, it might have already been switched to the trach ties. So if those have gotten soiled or anything, that's the tie that goes around their neck and holds the trach to them.
Place. Yep.
You might need to change those if they're getting soiled.
Yeah, and so one hospital I worked at, the nurse did all that, and then when I went to another hospital, that was like a respiratory therapy only situation. So it really depends on the hospital. I really liked that respiratory did that because the trachs really freaked me out. But then also it's gosh, there's yet another complex thing to do in my time management, and it was very difficult to. You do what you got to do, but it was just nice to have this, and also the respiratory people who know all things respiratory are dealing with it.
Right. This is their jam.
Yeah. And it was not mine. Oh. But anyways, so they would have fresh peg, fresh trach, fresh incisions, wound vac to their leg. They would probably, would they go home with that wound vac?
It can depend. On how it's healing, on doctor's preference, on lots of things.
All right, just curious.
Yeah.
This is a thing you said that I was not familiar with. So you doing obviously the Q4 vascular checks, incision checks, and that the patient has an internal Doppler. Tell me about this stuff.
Yeah. So the flap that we're referring to, that is the part of the leg that we brought up and have attached now to their neck and their jaw. And that is all vascularized, and we want to make sure that it stays getting good perfusion. So we need to do these vascular checks, Q4. And so at least at my facility, we have implanted Doppler. So it's a little wire that's snuggled into their skin, and it is giving you just a constant reading of the like pulse in that area.
Interesting.
So it's attached to a little thing at the head of their bed, a little machine, and it's just constantly, you can see the pulse right there in the middle of the flap.
Do you just have to chart that it's present every 4 hours kind of thing?
Yep. So like you just turn the volume up, make sure you hear the whoop, whoop, whoop.
Oh yeah, from the Doppler.
Whoop, yep.
Oh.
And then you turn it back down because it is eerie to be hearing a pulse constantly.
Yes, that would be. Yeah.
So you just chart that the pulse is present there, and then you physically do the assessment of, temperature.
Okay, looking at it.
Asking sensation. A lot of times, like I said, if she's got numbness, that's not unexpected. The nerve. Let's see. I'm not sure if they can what they do with nerves. I'm not sure if like the sensation will come back eventually or that, but numbness is not uncommon.
Okay.
And then let's see, temperature, color, sensation. Yeah.
All the things.
Yeah.
That's super interesting to me. But it's good to know that so that's put in the OR kind of thing. Yes. Is that something when they're done with it that you take out?
No, that will be taken out by the surgery team.
Okay. Oh, interesting. Yeah. All right. Let's see. What else did I want to ask you about? Oh, you said Q8 incision care with half and half. What's that mean?
Yeah. So some more lingo. So half and half. This is half hydrogen peroxide, half sterile water. Again, this will be in your order of what you are to clean the incision with. And then the bacitracin is like the antibiotic ointment that will typically be in your MAR like for a scheduled time. So you'll do your incision care at that.
So every 8 hours, you got to take care of that bad boy.
Yep. And their incision will be like open to air. So you're just going in with some gauze or the like cotton tip applicators and getting kind of working away at the crusties that might be along there.
Okay.
And the hydrogen peroxide helps to kind of dissolve things and sizzles up. And you're not going to get every single little bit of crust that first time that you clean their incision. So
don't be too meticulous.
You don't have to be there until it's perfect because the idea is that you are working away at it every time.
Okay.
Yep.
That makes sense.
Working at it, getting the new stuff.
Because I know some nurses who would sit there for way too long to like do that.
No.
Yeah. Don't be doing that. Got it. Makes sense. What else did I want to ask? So you had we already kind of talked about the donor site. So the patient obviously is NPO, nothing by mouth, always has to have suction nearby, not just for convenience, but for safety.
Yep. So teaching them how to use that effectively. So I said that it was attached to a Red Robin.
Oh, yes.
That is, it's pretty similar to what you use like the straight cath. It's the straight catheter. So you just hook that up to suction, and then the little hole at the end, they can put the tube in around their mouth and it sucks it right up.
So always one of those with these patients, when you're leaving the room, they have their call light and they have their suction.
Yes.
And then talk about blood sugar checks. This patient, didn't sound like they had a history of diabetes, but they've got Q4 blood sugars.
Yes. So they are NPO and they are getting the tube feeds. And so just as we are watching them, seeing how they adjust to their tube feeds, and probably before their tube feeds actually started, they are NPO, getting frequent checks to make sure that they didn't drop or go very high. So those will continue until we make sure that they are stable on their tube feeds. And we need them to be stable because they've got a lot of healing to do, and we don't want high blood sugars or low blood sugars.
Right. High, I think it's over 200. If the blood sugar's over that, your body just can't heal. because the sugar's too high or the glucose is too high. She's got all these incisions, all this stuff that really we need to set her body up to be, in success to heal. So often in ICU, they might have more tight management. And then as she gets to the floor and, you see trends and whatnot, then it's like you can, okay, here's every 4 hours and here's our scale of how much insulin. And it's important that we get that blood sugar under control and consistently so our body can heal from this huge, massive surgery she just had.
And you might have an order that says, after however many hours, if no intervention needed, then you can cancel the order.
Yeah.
There might be like a nurse-driven sort of thing, so you're not poking this patient 12 days later when they don't still need it.
And yeah, I've seen that happen too, where nurses are hesitant to discontinue those kinds of orders. But if you have an order that says, hey, if they've had X amount of normal blood sugars to discontinue this order, dear Lord, please do that. We don't want to be poking people and giving, checking their blood sugar unnecessarily. Actually, my dad was recently in the hospital, and that's one of those things that happened where I knew he never had a history of diabetes. He's always had his blood sugar under control. And most ICUs will say, hey, check their blood sugar on arrival. But then some people can get into the habit of just checking everybody's blood sugar because they think, but it's like, if this patient doesn't truly need their blood sugar checked, get rid of that order.
Yeah.
That sucks getting your finger poked. And then if I found out later, we never really need it. Come on.
Come on.
Don't wake me up to poke my finger.
Right, at midnight and then 4 a.m.
If I don't need it.
Right.
All right, so I think those were all the little flap vascular checks. Did you talk about that?
Yeah. The Doppler.
Okay.
Yes.
Sorry.
Yes.
Go ahead. You were going to say something
I was going to say, with the PEG tube, so that is how you're delivering your, quote, oral medications.
Yep.
So you might have some medications that you crush and then dissolve in water and you can push through. You might have liquid medications ordered. So like I said, she's got the hydrocodone that is liquid and that you can push through. Be very careful about those medications that have the little box at the bottom that say do not crush or chew.
Yes.
Do not crush those. Those are likely extended release style. They can often be heart rate or blood pressure medications. You don't want all of that hitting immediately when it's supposed to.
Like Toprolol XL, common one. Don't be opening up that capsule. I can't remember if it's a capsule or not, but notice if it says extended release on the name of it, that is a big red flag that it should not be crushed at all. And then there's I would get into because you're going to have these patients on your unit for a little bit. I would just get into the habit of double checking to make sure the med, if you're not sure if it can be crushed, just double check.
Yeah, you can call pharmacy, see if it can be crushed, or if it can't, then they need to switch it to a liquid form, or like the Toprolol XL, maybe we need to go to the short form acting that we can crush. We just do it more often than the extended release. But it is unsafe to crush and give all of that at once.
And then there's also a few meds, not a huge list, but there are some meds that can't be given right next to or within boluses or tube feeding.
Yeah, so a really common one would be Synthroid, like thyroid medication. And often your tube feeding order will say, make sure that you hold for 1 hour or 2 hours or whatever before and after giving this medication. So be mindful of that as well when you're doing tube feedings.
Yep. And then, obviously giving these patients meds is going to take longer.
Yes, it is.
So you're going to want to consider that in your time management. So if you got 4 other patients who you can just get pills and hand them to them and they can take them versus you have to crush, get elixir, get water to flush. It simply takes longer. So caring for these patients, you really have to consider that in your time management.
Yeah. And if you are maybe the day shift nurse and you're going in there around 8, 12, and 4 to be doing the feeds with them, you're going to be spending a chunk of time in there. What else can we do while we're in there?
Cluster that care. Let's do it.
Let's, what other meds can we do at that time?
Yeah.
You're in the room, do the whole shebang.
And if it's appropriate, and if this is a schedule that's not going to change in my mind, I'm like, okay, if I've got all my meds scheduled at like a different time? Is there any reason we can't reschedule to have these all? So, because then that also helps if it doesn't matter, as long as I get it daily, like don't have it, and you have to be in there at this time, if there's a way that it can be retimed to make it so that you're not, waking up the patient or, give them a break and not have to like go in many times unnecessarily. Yeah. So that's very important considerations. So let's say you just flipping again, you're the day shift nurse that just got that report. And we just kind of talked about some time management with how long it will take to do certain tasks. But what kind of things are you thinking about for this lady for the shift? What kind of goals do you have?
So, as I'm like walking back to my computer, the things that I'm thinking about are that first time that I go in the room, I've got a lot to do. I know that I have a feeding to do. I know that I'm going to do my full assessment on everything. So I want to make sure that I have feeding. I have tube feeds up here. If I don't, I got to order that. That's going to throw off my time management a little bit. My other meds, I make sure that I have them. I want to be prepared when I go in this room. I don't want to be running out.
Because you could run in and out 10 times because you need a lot of stuff.
Yeah. So let's see. Starting out the day with this patient, some of my priorities are going to depend on where they are in their hospital stay as far as what goals we've got. Are they going to be going home in just a couple days, and we can start talking about them doing the tube feeds themselves. We can start talking and educating them, having them try that first. Where's our trach at? Are we going to be downsizing? Are we going to be decannulating, removing the tube before discharge?
And for people who aren't familiar with trachs, that's like you have this kind of progression where you put it in at one size, and then you get it smaller and smaller, and then you
can cap it.
Yes,
for a
and they
couple
can get
days.
a speaking valve. Ooh, could they get a speaking valve? I guess it depends on if part of their tongue's removed. How does that work? I've never thought about that.
Depends so much on the anatomy and like the specific case.
Yeah. Oh, that's interesting to think about though. But there's different steps with a trach. It's not just you pop it in and it's all done. There's like things you need to do and goals that have to be kind of achieved and that kind of thing.
Yes. I am looking at just like the full assessment and making sure that they're healing appropriately. We just had this major surgery, making sure they're healing appropriately. And a lot of times these patients do go home, and as opposed to like, rehab or nursing facility or something, a lot of times these patients go home. So by the time they are on the floor with me, downgraded from the ICU, they're on the floor. We are very discharge oriented in terms of making sure things are set up. As far as having equipment at home, if they will need home care, if what they're doing themselves. So especially for this patient, since they've got so much going on that's going to go home with them, that's going to be huge.
So you're working, I'm assuming you're going to be working a lot with case management and social work to like make sure they've got all the equipment at their house, insurance, whatever pre-auths need to get, that all's been started, and you've got all the orders you need from the physician, and there's a lot of stuff to facilitate.
It is. And things may move slower if we've got that communication barrier of the patient isn't able to talk normally. So again, depending on what specific surgery they do, they may be able to like mouth some things or just, their voice is hoarse, but they can try and like whisper things. Sometimes they might not be able to at all. And so then you rely on them writing.
Have you ever had one that can't write?
Yes. I have had a patient who's either their handwriting is not, or their spelling, handwriting, their literacy, have trouble communicating with us, or like what we're saying to them, they can't,
they don't comprehend.
Right.
I've had that too, where that seriously complicates things and I wasn't even thinking about it. And then I'm like, write down the things you need for us to get for your discharge. And they were illiterate and I did not know. And it makes, you want to make sure all their needs are met, but it's very difficult to do that when you can't, we have this massive communication barrier.
Yeah. We had a patient who was on our floor for a very long time, like several weeks, who had a Larry tube, so in the larynx, and couldn't speak. And her handwriting waxed and waned depending on how well she was that day. And like she would try and, when she would ask for a medication, like she would try and spell it and it's completely wrong. And I don't know like what you're spelling, like what kind of medication, like you have to like pull out, you have to be very good at asking questions.
Like turning things into yes or no's.
Yes, it's so difficult.
Yeah.
It's so difficult. I so often will ask a question, but I'll phrase it as a this or that.
Mm-hmm.
Let's do this, blah, 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 or we can blah, 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 blah. And they're like, I can't respond to that whole answer. Yeah. So definitely training yourself to yes and no's. Mm-hmm. And if it helps to have like a frequently used sort of paper, asking, if it has bedside commode or, suction, just a paper that they can point to more easily than them writing every time.
Speech therapy may have communication boards that are like, because when I worked on neurocritical care, we had aphasia issues and different kinds of aphasia, but it was, helpful if you could even just write down the alphabet and they could point to letters or circle yes or no, or point to like commode. And even if they can't read, they can have, you can get some with pictures of a toilet or food, whatever you can do, because you have to communicate with them.
Right. These patients are awake and alert and have needs, and you are the one that can provide it. You just have to know what you need to provide. Yeah,
this isn't some intubated, sedated, snowed person. This one is alert. They can hit that call bell.
They have questions. Mm-hmm. They have questions about discharge.
Legit questions.
Right. They have, it can be difficult. So prepare that in your mind for your time management. This is probably going to take a hot minute. All right, cool. So, but this, like, in our last episode, we were talking about our trauma patient that had all this, fractures. This is not the same in terms of pain management, I'm assuming. While they do have pain management, it's not going to probably be near as complex or as big of a focal point, I'm guessing. Yeah, I would say so. Typically for these patients, these are the ones that, they're as needed medications. We're more on the like as needed, level. They certainly have surgical incisions. I've often heard that like the leg portion hurts maybe more than the jaw if they have decreased sensation all up in their jaw.
Makes sense.
So assessing all of that, the jaw is the one that you see. So if you ask, how is your jaw feeling? And they answer that question, and you don't ask about the leg that's underneath the blankets.
Yes. Great point.
And unfortunately for these patients, asking an open-ended question, how are you feeling today, is inefficient.
You know what? I've made that mistake too before with patients who can only do yes, no's, and I keep asking open-ended questions, and I'm like, oh my
We learned all through nursing school to ask open-ended questions.
And now I can't do that.
And we got so good at it.
Yes. But anyways.
Yeah. Okay. So I don't even know what I was saying about.
Well, we're just talking about your kind of mental priorities for this patient after you get report, things you need to situate for the day.
Yeah, very, like I was saying, very discharge oriented. Those needs at home and working towards meeting them. Mm-hmm. Pain control, they can go home on that hydrocodone, that liquid form. It's just like sending someone with a Norco script.
Right.
They get a script for the liquid that they pick up, and explaining the decrease in, stepping down pain medications, so Tylenol as you get better, all of that, like discharge information.
Great. Okay, so that's kind of keeping in your brain. So when you go into the room with this patient, we've kind of already touched on like what your assessment specifications would be. I don't know if was there any others, like you go in the room and you're obviously looking at your incisions and that Doppler. your wound vac to make sure it is, sealed
Yeah,
and working.
Yeah, biggest thing with wound vac is making sure that it's holding a seal. So like I said, wound vac at 125. So that's the amount of pressure that will be prescribed. Might be 75 or 100 or 125 is quite common.
Yeah.
So making sure that it is holding that seal. If it's not doing its job. So you notify whether the surgical team is managing it or like a wound team is, helping out. Just notifying so that someone can either come and change it or you can try and patch it. At nighttime, we do a bit of patching for wound vacs.
To get to the next day.
Right, to just try and hold a seal till the next day. It's not a perfect system, but it's holding enough pressure, to get to the next day. Maybe we don't get up as often because it moves everything around and,
Yeah, that's like that critical thinking. Okay, this is an important thing, but not a wake people up who need to do surgery the next day situation.
Yes. Got it. If we can patch it and we can hold the seal and we kind of press like this and the patient lays like that, we'll do it for the next 3 hours till someone gets here in the morning.
Yes. Love that critical thinking. Okay. Anything else that you're kind of thinking of? You're very conscientious of making sure your meds are appropriate for the PEG tube. And they're got their nutrition and they're tolerating it.
Yeah.
Probably maybe having a little diarrhea.
Yep. The tube feeding can give you kind of loose and sticky bowel movements.
Yep.
And if you're early in this process, you may not be at goal for your tube feeds. That's kind of how to say at goal. We may start with smaller amounts and be working our way up with each feeding over the course of a day or two. And so when you do that feeding, assessing how they're tolerating it for nausea, bloating, all of that. And so that if they do tolerate it well, then the next time you can move up to that increased volume.
Yeah, because it's like the body's not used to getting all of its nutrition in this like liquid weird form. And if you all of a sudden give it a ton and your body's, the dietitian does calculations to figure out what this person of this weight and height and all that, they do those calculations. Okay, they need this kind and this much. But if you just throw that down their stomach, like the body does not love that.
Right.
So we got to ease into it.
Introduce it to this new idea.
Yes. Because it'll give them like their stomach will hurt. They'll be nauseous. You don't want this patient puking.
Yep. You do not.
You do not. You also don't want them to be constantly having diarrhea. Like, so we got to, take our time with that, but that's something to be cognizant of and making sure they're tolerating it fine.
If your facility is one that most patients get prescribed stool softener and laxative just daily, every day, daily for everyone, this patient may likely not need those laxatives because the tube feed itself softens things up and moves them along.
Yep. So having that kind of critical thinking, because there are a lot of policies and like admission order sets that pretty much give everybody a Colace twice a day or whatever it is. Yeah. And it's like, well, let's
think about.
Maybe the person who put in the admission order set is not the same person who put in the order set for the tube feeding. And doesn't think, oh, wait, maybe I should hold this or put in an indication that says hold for loose stools or whatever it might be. So we got to use our, critical thinking so we don't mess up their GI system. Yeah.
It's already adjusting to something
massive. Yeah. All right. So let's see. I want to make sure. So you walked in the room and you're pretty much looking at all the things we already chatted about. What are some big complications with this kind of a patient?
So some things that can kind of make you nervous, obviously, are the trach. So that's their airway.
I'm already nervous.
It's pretty important.
Calm me down.
So if you are working on a floor, if you are new, if you're orienting and you're going to be working on a floor that takes these trach patients, be sure during your orientation you try and get as many as you can because trach care is just something you have to be comfortable with. Suctioning is something you have to be comfortable with.
Don't avoid it and say, no, I'm good, I got it. And then you have it on your own and you're like, I don't know what to do.
Yeah. And being able to just like, all right, patient needs suction now, let's go. Yeah. And like, grab this, grab that, ready, set, go.
Yeah.
Because they're going to be appearing like they're in, a lot of distress if they are, either trying to cough up or they can't cough up. They've got something plugging them up down there. They're turning red in the face. Their SpO2 is beeping very loudly.
I'm anxious. This is the worst because I remember being in that situation before I, got comfortable with it. And now if I went back to the unit, I would have to be retrained, to be honest, because it's been so long. But it's like, that is a very they look so helpless and scared because they're coughing. They've got the trach that's new and they can't breathe. But it is something you can totally handle completely independently. But there are steps you have to follow to get situated to safely suction the trach.
This is the patient you always want suction set up. You want suction set up at the wall. You just have the tube completely ready. Keep it on. Doesn't matter. It's completely set up. And then you always on your little shelf or your table or whatever, have a suction kit, a sterile gloves.
Yeah, so you get a stack of them, so that you have them right there. And if you're admitting this patient to the unit, you have that suction set up because you will need it.
Yeah, you'll need one suction for their oral thing that they're going to have in their hand all the time. And then you'll have another suction on this side of the bed that's ready for trach care, so you're not fumbling, switching between the two. That one's buried in the bed.
Yep.
Yep.
Yep. So this, their airway is such a big deal. The biggest deal.
Yeah. So definitely trach care when they need suctioning. That's they need suctioning now sort of thing.
That can't be delegated or wait.
I'll get there in a few.
Yeah.
So with the trach, if you are ever struggling with the trach, if you have suctioned this patient and they're still struggling, give a respiratory a call.
Yeah.
Get the respiratory therapist there. They're usually well aware of who their trach patients are. They come around and do rounds. They will suction if they need to. They're aware of these patients, so just say, "Hey, something's going on. Blah blah blah. Can you come look at them?" Because they're the pros at airway at trachs.
Yeah, and if you're new and you stay in there with them while they're doing it. There's so many are so good at teaching.
Don't just peace out. You got this.
Yeah.
Learn from them.
Yeah, because you know what? There's going to be times when they're dealing with another emergency and you got to kind of handle stuff yourself. And so the more you can, learn that kind of stuff and empower yourself by learning that, taking that initiative it's good. Because while they should always be there or someone should be able to come, sometimes things happen and they can't get there as fast as they need to or whatever it might be. So, all right. Any other, the airway, the big one, any other big one? What if, do you ever turn the pulse thingy on and you can't hear the pulse?
Yeah, that would be a call doctor right away.
Yeah. In the middle of the night.
Yeah. Just because if you've lost, a pulse there, you've lost the vascularization to there, that flap may not take, that flap might start dying.
So they would have to go straight to the OR kind of thing?
That is a call doctor to come see. Maybe it's an issue with the Doppler, whatever, but we need them to be aware and we're going to problem solve together. That's not a wait till morning sort of thing if you've lost a pulse over there.
So very different than the wound vac on the leg of not being totally sealed. We can kind of get this to the next day, but if we are turning on that Doppler and not hearing the pulse, then holy moly, let's call.
Yeah.
Okay.
Yeah. And of course, doing your additional whole vascular assessment of it, so that when
they're going to ask,
when you do call, you don't want to be on the, the Doppler, there's no pulse. The Doppler isn't giving us a pulse. They're going to ask, is it warm? Is it red?
Yep.
Is it soft? How does it feel? And you're like, I don't know.
Let me go check. Let me put you on hold for 3 minutes.
Just woke you up, but hold on.
But hold on, and let me put on my isolation gown because they're on isolation, and then the patient's got 4 questions, and it's like, no, wait. Yeah, always find that information out before you call.
Yeah, so if you're assessing and you're not seeing a pulse there, hearing a pulse, feel that it's warm. Ask the patient, does it feel any different? What's the pain feel like? Is the numbness any different? All of those questions so that you kind of have all the information before you call, but call now.
Yeah, and if you're not sure, you could always ask your charge nurse, what all should I look at? Because my guess is if the Doppler's not picking up, but all that other stuff looks great, They may say, oh, there's something wrong with the actual Doppler, that, but if you're like, well, it feels kind of cooler. And that's why also at the beginning, your first assessment, so you can have a baseline to refer back to, because you're like, well, I don't know if it was different than earlier.
Yeah,
Like,
I didn't feel the temperature earlier, so I'm not sure.
Yeah, make sure you have a solid baseline assessment where if you're not sure, you think back, is this the same incision I looked at 8 hours ago or whatever that was, so you can have kind of a reference point to quantify the change, because that's what the kind of information that they need to make a clinical decision, because they're not there. They need you to be their eyes. All right, that's a big one. Okay, any other big like complication kind of things? Those seem probably the biggest.
Yeah, we got our airway breathing and we got our circulation.
Yeah, there we go. Yeah, because these, this isn't like the cardiac patient from the ICU that just had a cabbage. While you're going to pay attention to their cardiac status, this is a little different.
Right. Yeah. I mean, you're looking at their vitals every time, and if there's an issue with that, sure. But these are the kind of specific to this case.
Big tips for anybody who would be taking care of one of these patients.
Big tips. So if don't be scared.
Yeah, I feel like, that would be jarring to take care of, have that responsibility for that. And then, this patient probably looks very different, and talking to there's just so much.
Don't be scared. And if you are orienting on a floor where they have a complex patient like this, don't be afraid to take it on early. Maybe this is one of your 2 patients. Or maybe if this is your first week, it's okay to have this one patient as your patient. You're going to learn so much. You're going to learn how to do so much. And when you have the time to do it, on your orientation, earlier in your orientation, this is the time to take advantage of it.
Yeah. I hear you saying, don't avoid this, dive into it. It's not going away. So you might as well jump in.
Right.
Yeah.
There's so much the trach can be intimidating, but, tube feeds can apply all over the hospital.
Yep.
Incision care, wound backs can apply all over the hospital. Dive in.
Wonderful experience.
Don't be scared. You're being oriented by someone who does know what they're doing. Learn. Whenever you have trach patients, try and get some experience with them, because that's truly the best way, is just getting comfortable with them. Yeah,
because you can only read so much about them. You really have to physically be there, do it.
To be able to keep your calm while that crazy little situation is going on, to be able to say, oh, let me go grab this. Okay, we're going to do that, and we're going.
And be confident and calm.
You know what's going on. You know what you're going to do. You're moving calmly.
Yeah, because if you're freaked out, it's going to make it worse, because that patient's not going to trust you. They're going to be scared and whatever. So you do, but that takes reps. You got to get your muscle memory in there of doing that over and over again.
You might be scared. I'm still scared too. My patient isn't breathing well. I'm not saying I'm not worried, but I've got something in front of me that I'm going to try, and I think it's probably going to work.
Yep.
So let's go ahead and try it.
And you're going to have that nurse poker face on, where, you know what, even if you're freaking out, nobody knows. Well, you want the beautiful thing I love about nurses is their patients can have no idea that they're freaking out. But if I'm with the nurses that I work with every day, I know when they're worried, even though they don't look worried. Yeah. Like, that's just how nurses know each other, how teamwork works. Is like, I know when Hannah is worried, she's not saying it, but I can tell by the way she's moving, how fast she's moving, the way her eyes look, the way she's answering questions, that it's going down.
It's like a very controlled, different
response.
Like, we're in a situation right now. I'm going to move this way.
Yep.
I'm going to talk this way.
Instead of, this is what's going on. No, this is what's going on.
Right. But I'm not up here, and I'm not freaking out, and I'm not telling,
I'm not going over every little thing. Yeah. There's this different place to be.
That nurse poker face.
Yes. It's a beautiful thing. All right. Well, is that anything else on this kind of patient?
I think that is it.
That was so enlightening to me. I really enjoyed hearing about that.
I love these complex patients.
Ooh, yes. Yes. Ooh, yes. All right. Well, thanks, Hannah. We'll have you back for some more episodes, and stay fresh.
And clear the room. You walked in and we're all doomed. So hazy, smoke in the air, from your lips to your legs to your hips to your hair. Sound the alarm and evacuate. I want you to myself, but I can't wait.